All right, let's do a proper assessment. If you get any of the vibes today that you went into a doctor and they're telling you have a meniscus tear and you need surgery, but they didn't touch your knee, I would love to assess your knee for you because you need to do the proper assessment to know exactly what's wrong with it. Good morning, good day, good afternoon, whatever time frame you're in. It's morning here, but welcome to Straight to Health. My name is Dr. Gavin Hall with Straight Up Chiropractic here in St. George, Utah. Today, thank you for joining us on the podcast. Let me actually welcome you in that way. Thank you for listening. I hope you've listened to previous episodes and found it educational. The purpose of this podcast is to educate you. If you don't know more about your body, we want to teach you about your body, and that's the purpose. So let's get straight to health. Now, previous episode, I talked about ankle injuries. Today, we're going to cover the knee. My next episode, we're going to cover hip information. So if you have any knee injuries and you're thinking, oh my gosh, I don't know what's wrong and I don't want to go to the doctor, I don't want to see a physician, then listen in. Maybe I can cover a little bit of your injury and help you kind of decide where to go for your injury. We're going to start with, like I mentioned, the knee today. It's a pretty cool joint. It's pretty simple, but there are a lot of different problems that happen with such a simple hinge-style joint. There are 9 ligaments and 18 muscles in the joint. You've probably heard of a couple of these. We're going to start off with the ligaments, more of the ligament-style damage or injuries, and then move on to the muscles. So let's get started. The first few that we're going to talk about are the dreaded ACL tear, the MCL tear, the PCL tear, and the LCL tear. ACL is anterior cruciate ligament. Then we have the P is posterior, meaning backside, anterior meaning front side, posterior meaning backside, collateral ligament. And then we have the MCL, which is medial, which is inside. If you're talking the right knee, it's inside on the left. If it's the left knee, it's inside on the right, if that makes sense. But it's towards the inside. And then lateral collateral ligament is the outside of the knee. So if you have pain on the outside, kind of where the outside of the hamstrings kind of come in, then we're talking in that. But we're going to talk about each of them individually. Let's start with the ACL, the anterior cruciate ligament, or we also call it, I was talking about so we have the ACL, and it can tear or it can sprain. A tear, as we've talked about in previous episodes, is when that structure fully separates, all right? If it's a partial tear or just a sprain, all right, remember we talked about this last time, the strain versus a sprain. Strain is muscle, sprain is for ligaments. In this case, this ligament, this ACL, can sprain, all right? So you can sprain it and it can hurt, but it will heal a lot better than a tear because that tear is a full separation of that ligament, all right? The best way to tell if you have an ACL tear is twofold. The first is the story. How the heck did you tear it? All right? Most of the time, most commonly, it happens when you stop very quickly. It's very much an athletic style injury. It's if you stop and rotate. So when you pivot is most commonly when it tears or sprains, okay? It'll bring on pain on the front side of the knee. And if you Google or YouTube, I'm sure there are plenty of people. I want to do my own videos on this, but I don't know that I will just because I'm sure there are 100 other physicians who have done videos on how to test an ACL, all right? It might save you a couple bucks if you test an ACL at home on YouTube, and then if you're like, oh crap, I think it's broken, then go and see a physician. But it'll save you some money there if you're like, well, I don't know what the heck is happening. Just Google how to test for an ACL tear, and that should come up relatively quickly. But basically, you just have to pull on the knee with the person laying on the injured person laying on their back. You're going to kind of tug on their knee towards you, and if it pulls towards you, it's because that ligament isn't holding on to it. You don't want the knee to move when you're pulling on it. The ligaments are supposed to hold it all together. So that's kind of the simple version there. If you do have a full tear, not even aim it. I can't help with that. All right. You need to get the tear repaired first, then we can mess with it afterwards. But I will say there are a good number of tears that will heal on their own. It's tough to say what the body will do. The body has two options in this case. It can say, no, I know what to do with this. Let's heal it back together. Or it can say, this is torn. But if you don't get it fixed, so the body just doesn't leave stuff hanging around, it will actually absorb those frayed ligaments. Or if you think of the ligament kind of like a rope, that if it snaps, it often has frayed ends. And so it's not super easy just to grab the two ends and sew them back together, because how do you grab all these different fibers and stick one to the other? Super glue doesn't do it, you know what I mean? So what they'll do is they'll either replace it with a different or cadaver ligament, depending on how it tore. If it didn't fray but it split, then they can typically grab those two sides and stick them back together. That's in the surgery realm, though. I don't know all the details with that, other than most of those repairs are relatively quick. They're simple as far as the efficacy thereof. They just grab those two sides, they connect the two ends, and so it heals relatively well. You can choose not to get it fixed, though. There are cases where the body will just grab those two ends and kind of stick them back together. I would say most commonly, from my experience, the body will absorb it more than repair it. You will get a lot of scar tissue in the joint, and that's not going to help for future injuries. So oftentimes I'll just say, go get the tear repaired, then let's work on it. That same thing applies for the ACL, the PCL, the MCL, and the LCL. There are those four ligaments that are most commonly injured in the knee. And I would even say the MCL and ACL are most of the four of those, the ACL and MCL are most commonly done, because they're injured very much by stopping and rotating. So I think that's all I want to cover on the ACL tear. If you have questions on that one, definitely contact a local physician. With any of these that I'm covering today, I'm offering suggestions. Let's cover for the sake of be smart. Don't hate me just for giving you wrong information if I don't apply correctly to your injury. My goal is to educate you. You need to make a good decision about your care to see the right physician at the right time, all right? But the education is what I offer to try and help you make that decision effectively, all right? Now, the PCL is that back of the knee ligament. All right. In order to test that one, you're doing the same or similar. Have the person lay on their back, and you're going to push their knee. Instead of pull it, you're going to push on it. All right. That pushes the knee posteriorly or backwards. And when I say the knee, I mean the shin. All right. Push on the shin at the base of the knee. And if it shifts backwards a lot, then there's nothing holding it there. You've likely torn your posterior cruciate ligament. Okay. Most commonly, this one's injured by having a force that smacks. It's big in football, I would say, is probably the most common time that I've seen this injury. Someone smacks the front of your leg, all right? And if your knee is trying to stabilize and someone smacks the back of that leg, that whole knee is going to shift backwards, and that's typically where it jars. This ligament is on the back of the knee. It'll jar that ligament and tear it. All right, but the same thing applies to that one. A tear versus a sprain, same idea. If it's sprained, that's a great, let it heal on its own. I can help with that one with AIM-IT, NPI stuff to help it heal more effectively and quickly. There's also been if you guys agree with the hooky voodoo realm of essential oils, there's also a lot of essential oils will claim, not a lot of essential oils, wintergreen and peppermint oils have been shown to assist in the healing of ligaments. Take that for what it's worth. I agree with it, but not all physicians do. So kind of look into that. I typically recommend it for my patients. If they do have a sprain or a tear, I will put either wintergreen or peppermint on their injury because it does help it feel better. And in my opinion, it also helps with the healing process. The studies that have come out on that are done by essential oil producers or people who create it. So you have biased opinions there, but for the sake of if it feels better, sometimes it might be worth that few $30 bottle. Anyhow, I digress. Let's move on to the MCL. The MCL is on the inside of the knee. If you're looking at the left knee, from your own body, if you look down at your knees, the medial side is the inside. So on the left knee, it'll be the right side of the knee, and on the right side, it'll be the left side of the knee. All right, that is very similar to the other ones, the sprain versus a tear. This one is most commonly injured by what we call a valgus force. I'm going to cover that in a minute. I think it's actually after the ligaments. But a valgus is when the knee, the inside of the knee, drops inwards. If you can see kind of like this, how your knees might be, is that this knee will shift this way. So it's very common as well during a football tackle that they'll hit you from the side, and that inside of the knee will overstretch because the foot is planted with your cleats. And so those cleats will plant, someone else hits you from the side, and that ligament right here gets overstretched and tears. All right. The same thing happens with the lateral ligament on the outside of this, for the sake of this example, the right knee, okay, is if someone hits you from this side and overstretches that outside of the knee, then it will cause this ligament to tear. All right. Or it can sprain, just depends on how bad the hit was. The sprains will come back on their own. The tears, I recommend that you get that formally assessed based on the assessment. If you do feel that pulling or pushing and nothing's really stopping the knee, then the ligament's likely shot. If you're flexing the knee, that's not helping the assessment because muscles are stabilizing when you flex. You want the knee completely relaxed while you're messing with it. But Google these. I think a lot of the tests for these will be helpful if you Google it. Then if it is a problem, then definitely get in to see. If it is fully torn, you'll go straight to an MRI. Don't waste some time on an X-ray. You'll want to make sure that it's fully torn. And when I tell people about the MRI route, there's a couple of popular MRI study or businesses coming out where they'll do like a cash pay MRI for $400 to $500 instead of going the insurance route at like a hospital. Then I will typically tell people, hey, do the math. If you're paying cash $500 for your MRI, or you go to the hospital and you're going to be charged $2,000, but you have a high deductible and your insurance is going to pay half of that. The hospital is going to charge a lot, and you're going to have to cover the difference. And so oftentimes I'll say, I'd recommend you do the cash route almost every time. I don't think I've ever seen insurance pay more than you would end up paying out of pocket with just a cash service. Does that make sense? So, excuse me. That's kind of the idea when we're talking about the insurance versus the cash pay is if you want it to go towards your deductible, then by all means, you make that decision. Just be aware and look locally if you're like, oh crap, I need to get an MRI on this. Most cash pay MRI facilities won't require a doctor's note or a doctor's prescription to be able to attend that. If you go the insurance route, you will need a doctor's script, if you will, a referral card. Depends on who you talk to, what they call it. Now, I talked about the MCL a little bit, valgus force across the knee, stretching or tearing. The MCL are attached to the medial. Oh, there you go. The MCL fibers are attached to the medial meniscus, so they're often injured together. Between the ACL and MCL, as I mentioned, they're the most common ones. And because of the way that they injure, that rotational and outside force bending, it often will damage that inside or medial meniscus as well. So if you have an MCL sprain, they'll often do an MRI to make sure it's an MCL, tear. If you did tear your MCL, then they'll often do an MRI, and part of that MRI, they're probably going to say, oh my gosh, you also injured your meniscus because the MCL attaches to part of the meniscus. I think that's pretty much it. Everything applies to the ACL. From the ACL, everything applies to these other ligaments as well. LCL is the outside of the leg. We kind of talked about how that one's injured already. And that you're just going to shift. Google it, the best test for this. I think I've covered this one well. It's pretty straightforward as far as how to injure it and how it's repaired. All right, moving on to the meniscus tear. The meniscus tear is commonly from that plant and twist, just like the ligament tears are from. You have like 6 different common types. I'm actually going to show you the book here. If you are watching, let's see if I can get my fingers out of the way here. These are your common tear types for a meniscus. The simpler the tear, the better the likelihood of repair. All right, if it's a relatively, and by simple tear, if you see that picture again, the horizontal is a relatively, that one should fix itself. Longitudinal won't often fix itself. The anterior horn can fix itself. The posterior horn can fix itself. The flap tear, you will want surgery. And the bucket handle, you will want surgery. Those are just parts of the meniscus. It's so torn that you will get parts of the meniscus that just flap around. And if you get clicking or popping after, if you were told ever that you likely tore your meniscus and you never got it fixed and it got worse, or now you feel clicking and popping, or if you get to the point where you try and move the knee and get stuck in a spot, that's often because part of the meniscus has flapped over and it's just not letting it move. Okay, so be mindful of that. Definitely get that checked. So that's a surgical repair in most cases. With those posterior horn, anterior horn, and horizontal tears, there's actually been some cases of some studies that have come out that it's about a 50-50 shot whether you go and do let it heal on its own or do a surgical repair as far as efficacy therein. But the worse the tear, of course, you're going to want to get it surgically mended. Oftentimes with a bucket handle or a flap tear, they'll just carve out those flappy portions, and they'll kind of tack down all the loose portions to make sure it doesn't become a problem. So just be aware of that. That's your meniscus tear. I would also Google or YouTube how to test your meniscus. That's a relatively simple one. You can stand on the bad leg, and if you bend your knee about 5 degrees and then kind of shift your hips around, that'll put torsion. You want to add torsion to the knee because added torsion is going to make it hurt. All right, because it's going to compress the meniscus, and the compression is what stresses that tear a little bit more, and that's kind of what leads you to think, well, this is a tear versus more towards, no, I think it's just upset or it's sprained one of the ligaments instead of torn your meniscus. The only way to confirm that 100% like the ligaments is by MRI. Even some MRIs don't catch it if it's a small tear, and that's a good thing. If you think it's a small tear, but the MRI doesn't catch it, let it heal on its own. I would say let it do its own thing there. For the sake of what I can do for an MRI, not for an MRI, for a meniscus tear, if it's a small tear, we can greatly impact that with NPI and AMIT. Muscle activation, if you haven't heard about those and why they're important, definitely listen to the previous episodes. You can also listen to any of the content that's on our social media pages. It'll cover a bunch of that as well. But that's kind of the simple version with meniscus tear. Moving on to something called Chondromalacia patella. This has a lot of different names. I'm going to come through them all. It's called runner's knee. It's called patellofemoral syndrome. It's called patellofemoral arthritis. It's called anterior knee pain syndrome. It's called patellochondropathy. It's called retropatellar chondropathy. There's a lot of different names. Basically, this is pain on the front of the knee. All right, if I see if I can get a picture of the location more. Yeah, I don't have a great picture. But basically, this is the idea of, or definition of it, is that you get softening and degeneration of the cartilage on the backside of the patella or your kneecap, resulting from poor alignment of the location of the kneecap as it slides over the end of the femur with knee flexion. So basically, your knee looks something like this, and as it bends, it tries to bend in this way, more of like a sliding motion, if you will. But on the front of the knee, you have this kneecap. Bones don't like to rub on bones. That's what cartilage is for, okay? And so what God did for us is he put what's called a bursa in between the patella and the femur to keep those from rubbing. If you think of the bursa like a sponge, nice squishy little soft padded area, and every time that it bends, the patella or the kneecap's going to shift across it. And if you don't have that bursa in the right place, then it rubs on bones, and that's not great. And so then it inflames the back of the patella, starts to degenerate, and causes pain in that regard. So you can have pain. Typically, it's either above or below the kneecap. It's tomato, in my opinion. You get some arguments as to, no, this one's more above, or no, this one's more below. In my opinion, it can be on the sides of, it's just going to be around the entire kneecap. They'll say, oh, my kneecap hurts a lot, or, it's achy after I'm done running, or things like that. There's actually another one. Let me cover that real quick. It's not jumper's knee. It's knee bursitis. That bursa becomes inflamed oftentimes because of the kneecap not tracking effectively. All right, your knee bursitis is just going to be that swelling. It often comes with a lot of edema, which is swelling around the kneecap, because if the kneecap isn't tracking properly, then it kind of hits this bursa incorrectly, and it can cause that swelling in the bursa. You can also have something called a Baker's cyst. This is a little more on the bursa side, more on the Chondromalacia patella. But on the bursitis, a Baker's cyst is kind of significant swelling on the back side of the knee. It bubbles up. Oftentimes the best repair for this is you drain the cyst. That's the current repair for it. I've had quite a few actually though myself, that if we can re-engage the hamstrings on the back of the knee, then the stability comes back to the knee a little bit and the body just absorbs that or eats it back up, if you will. So yeah, that's your little bursitis versus your Chondromalacia patella. But we can AIMIT takes care of this relatively quickly. Muscle activation, we talked about the different names of it for their respective whoever taught yous. And a lot of people have kind of grabbed and done their own thing and called it something else anyway. So, but like I mentioned in previous episode, one of the original forms was AIMIT, and I was trained in AIMIT. So I still call it AIMIT for the sake of lack of confusion. I don't want to confuse people. Now, so that's your Chondromalacia patella. We typically will just activate the quads. For the patella bursitis, if I'm feeling more it's the bursa's fault rather than the patella or the kneecap's fault, I will do something. I will treat a muscle called the articularis genu. Articularis genu is a muscle that attaches to the top of the bursa. It's a dumb little muscle. I wasn't even taught this in anatomy class. Dumb little muscle called articularis genu. It connects from the femur, the top of the femur. I need anatomy structures here. But it connects from the top of the femur and then shoots down behind the kneecap and connects to the bursa itself. And so as you bend the knee, that muscle pulls on this bursa to kind of keep it tracking or keep it located behind the kneecap. And it's a super cool little muscle. We're not taught about it in anatomy, but I was taught about it when I was being trained for AIMIT, and it has made significant changes for that. I have achiness after I'm done working out. My knee is super swollen. Post-surgery, actually, let me cover that. The number of times I've fixed this muscle after surgery because someone said, I've got bone on bone and I need a knee replacement, or something like that, or a partial knee replacement. The knee replacement has aggravated and shut down a lot of muscles. And so if you do not get the rehab or the healing that you want from the knee, you likely have a lot of muscles shut down from it. But that articularis genu that connects to the bursa makes the biggest difference for the swelling that you get post-surgery, because the bursa is inflamed after being poked on and prodded and replaced. If they left it in there even, because it's kind of connected to the bone as it runs down the femur, and when they replace the femur, I'm sure there's going to go, oh crap, we got some of the bursa with it, so let's just, we'll take that out and not tell anyone. Anyway, so the bursa gets really upset during these knee replacement surgeries, and it will calm down quite a bit if we can re-engage that muscle that helps move it and helps it flow, blood flow through the bursa. Okay? So, sorry, I got a little bit on a tangent there. Chondromalacia patella, though, I focus more on the quads, a little bit more on the hamstrings. It's kind of where that patella or that kneecap sits and how it tracks. Okay, so next we're going to get to what's called genu valgum, verum, or recurvatum. Basically, what happens here is that the bones will sit funky. They call it bow-legged. They call it, what do they call it? Knock-kneed, all right? Knock-kneed and bow-legged. It's people that you can see, they're walking in the store and you're like behind them, you're like, I feel like your legs are going to collapse at any moment. There's reasons for there's a couple of theories for reasons for that, I should say. The first off is muscle weakness. If you have a knee that's shifting to one side and heavily favoring one side, it's typically because the other side that is separated, those muscles are not doing their job to pull it down. All right, so muscle activation can get a good correction. I wouldn't say a full correction because it depends on if you have these other causes. The most common reason for what we call a valgus, or your ankles will go out and your knees will knock in, all right? Your knock-kneed is what they call it. There's a lot of speculation there from when you were a kid that you sit in that W when you sit, if you bend your knees and you sit on your heels and your butt hits the ground and your ankles are to the sides, that is shifting those ankles outward and putting a lot of pressure and stressing the inside of your knees. And so there's actually a lot of speculation that that's the cause of those knocked kneed. All right. I would say the best way to fix that is if you have a kid who has that now, fix it now, get muscles active now, because by the time you're 25, you're done growing. All right. They say, oh, you're a grown adult at 18. You're a grown adult at 21 because now you can do different things. You're a grown adult at 26 because now you can finally rent a car and get off your parents' insurance. That I have different opinions on that. I apologize. But the idea here is that if you have scoliosis, if you have other bone conditions like knocked knee in this case, that I would say there's still hope for you until you're 25. As a whole, you're done growing at 25. So if you can wear a brace to help with the scoliosis or a brace to help with the knee, get the muscles active in scoliosis and the knee, and to help stabilize this a little bit better, then over the course of your growth until you're at 25-ish, we can typically see some good correction as well with the pain, okay? And you may not get a full correction of that knocked knee or that bow-legged, but the sooner you hop on that and try to correct it, the better it'll be, because most commonly, your average American especially is only going to gain weight with time. And the more weight that you add to a knocked knee, it's going to emphasize that even more. So try to get it corrected earlier. If you don't get it corrected, then let's get the muscles working. If you are overweight, lose some weight because it's not helping those knees bend in. So if you do find that being the case, let's get some muscles active. Let's get some brace put on there and help that grow now instead of later. Okay, it'll just, the sooner you hop on that, the better it'll help. So that was your valgum. Your varum is the opposite. It's bow-legged, and you see these guys walk around with these knees that go out wide. That's typically because of a growth thing. Their bones aren't growing the same. There are some things that have speculated to cause that. In my opinion, it's more bone related and growth related than it is you were sitting with your legs crossed wrong when you were a kid. So just be aware of that. If that is something that wants to be corrected, typically the correction there is surgical correction for the bow-legged. All right. Knock knees, you can do surgery as well to correct that, but I would say let's try some other stuff first. But anyhow, I would be happy to help with a genu varum or that bow-leggedness as well, just to see if we can get anywhere. If we can prevent a surgery, why not? Next I want to talk about is jumper's knee. They also call it a patellar tendinopathy. I hope when I was talking about the AMIT in previous episode, any tendinitis, tendinosis, tendinopathy, we can knock that out of the park with muscle activation. All right, if you have pain in your tendon of a muscle, that is right up our alley. We can home run almost every time. There are exceptions to that based on the case. I would say 1 in 20 people do not respond for their tendinopathy, but the remainder, I think they respond quite well. This also has a different name of patellar tendinopathy, patellar tendinosis, patellar tendinitis, and runner's knee, jumper's knee, runner's knee. This is just pain below your kneecap. From where your kneecap connects to your shin bone, that little tendon there is where this is going to cause pain. All right, and we can typically get a good amount of A lot of people actually think, in my opinion, they'll say, oh, you're just growing. It's growing pains. In my opinion, it's not so much that. So come on in. We can get that one repaired. We'll typically work on the gastrocs. We'll work on the quads, and we'll work on the hamstrings, a couple other muscles, and make sure that is working quite well. It's a relatively simple fix, in my opinion. All right, IT band tendinopathy. This is your outside of the knee. Most of this pain is located if on the right knee. It's on the outside where that IT band. I hope you know where IT band is. If you don't, it's on the outside of your leg, and it kind of runs from your hip all the way down to your knee. That hip muscle. So the IT band is not the problem. The IT band is a ligament. Okay, the IT band does not contract. It's a ligament. Ligaments don't contract. At the top of the IT band, though, you have a muscle called the tensor fascia lata, or the TFL for short. And if that muscle isn't contracting, then the band that it connects to won't move effectively. So oftentimes, if you get pain on the outside of your knee, they theorize it's because it's chafing, all right? The muscle's not working right, so the IT band chafes on the outside of the knee, and it causes this significant pain almost always in runners. But the the solution is get the muscle contracting. That tensor fascia lata on the outside of the hip, get it moving effectively. You also have the glute maximus that comes down and attaches to the back side of the IT band. You have a couple other muscles that attach to the IT band. If you can straighten up those muscles and get it to pull effectively, it doesn't chafe, pain goes away. This is also one of the easiest ones to fix, easiest problems to fix in runners. So via AMIT or NPI is actually great. I think that covers that one relatively quickly. There's no way to really check and see if it's IT band syndrome. There's no special test. If you've got pain on the outside of the knee and it comes after you run or during your run, then it's pretty close going to be that problem. There aren't very many things on the outside of the knee other than your lateral meniscus. We covered meniscus. We talked mostly about the medial meniscus just because it's the most common injured. You can certainly damage your lateral meniscus. It's just less common. So refer back to my comments on the meniscus in general. It depends on how you kind of shifted and which way you're pivoting that made that meniscus damaged or injured, okay? IT band now we've covered. The knee bursitis we've covered as well. I talked about that. Osteochondritis dissecans. This is bone or cartilage that degenerates in fragments. They call it joint mice for those of you who like the nitty-gritty. Those fragments invade the joint space. This happens typically after an injury, or it could be because the bone isn't getting enough blood supply. And so it's an unhealthy bone that kind of just starts to fall apart. All right, but oftentimes what happens is that these bones will fall apart or fall off of the bottom of your femur and get into the joint and just pop off into the joint. And then you get stuck and the bone tries to shift, right? And this little nugget of bone, if you will, gets stuck or locks this knee into place in different times. And I cannot help that. That is, you're going to want to go see a physician. You'll want to get an X-ray, MRI, and find out what the heck is going on there and get those pieces removed, and then try and fix the underlying cause. Oftentimes because you have weak bones or there's some other disease there, like an infection or something. That's, if you're in that realm, definitely look at someone else, because I won't be able to help you there, unfortunately. But it is a significant problem, and it's going to need some good repair. All right, next is Osgood-Schlatter's disease. Osgood-Schlatter's disease is something we call apophysitis of the tibial tuberosity. So we talked about the kneecap. Below the kneecap, you have a tendon that goes from the kneecap to the shin bone. All right, as that kneecap or that tendon starts to pull, if you're a runner or a soccer player or I don't know that I'd see it tons in volleyball. You do get a lot in basketball, I'd say. A lot of the running things. I wouldn't say it's super common in football, but anyhow, it's usually a younger teen or child that gets pain right along the top of their shin where that ligament goes from the kneecap down to the shin bone, and they get pain right at that shin, right where it attaches to the top of the shin. And that's typically because of the amount of pulling and stress that happens on that ligament to the bone. And so as that ligament's pulling on the bone, it just causes inflammation. And if you have this long term because you run so much, then it will actually start to pull slowly off the bone, and you'll get this little lump on the front of your shin because of that. We've been able to help a lot of the symptoms with that, the pain associated with Osgood-Schlatters, by activating the quads, make sure they're contracting effectively, activating the hamstrings, because if the hamstrings aren't taking that load, the quads are. And if the adductors on the inside of your leg aren't taking that load, the quads likely are. And so the more that the quads have to compensate, the more they will pull on that tendon. All the quads come down to the kneecap to attach, and then that kneecap shoots down to the shin. So all of the quads, all that tension and torsion and force is going through the kneecap and that one ligament. So if we distribute that load back onto the hamstrings, back onto the adductors, you can get some significant improvement with Osgood-Schlatter disease and a lot of pain in the knee in general. That's typically with any pain or achiness in the knee. The problem is often muscles compensating, all right? And so if we get the compensation or distribute that load throughout more musculature, then the pain goes away. I've treated a lot of people with knee pains, and it's pretty great. There's a couple of people who are pleasantly surprised by the time we get done with the knee. You can have a patellar dislocation. A patellar dislocation it's that kneecap, patella being kneecap. It's when that kneecap shifts. All right, so if you look at someone's leg and you're like, your kneecap is not in the right spot, that's likely a patellar dislocation. The easiest way to fix is to push it back where it belongs, push it back towards the center of the knee. Most commonly, the kneecap will dislocate what we call laterally or outside, towards the outside of the knee, and we'll just grab that and push it back into place. That's one of the dislocations. Formally, do not do this. You're not a doctor. Don't do it. Go and get it done by someone else. But also all you need to do is push that kneecap to the center of the knee again. So I didn't tell you to do it yourself. Make sure you see a doctor about it. All right. But that patellar dislocation often comes because it's almost often a trauma, or you've overstretched or overstressed the outside of the quads. So on the right knee, if those quads on the outside of your knee will pull super hard because you were trying to pivot super fast, or you had a very quick contraction of the quad, then it will pull that kneecap. Most commonly, I'd say, though, it is because you had someone traumatized, you hit or brushed by someone in football or something like that, and the kneecap was just tinked off to the side. You have a ligament that's supposed to keep that kneecap medially, or is centered on the knee, and if someone hits the kneecap, it will snap that ligament, and then you got this kneecap that sits out funny. The quads, because of their strength and their power that all comes through that kneecap, like we talked about, will often hold that kneecap in place. So you often just have to shift or shove that kneecap back into its position. It should stay just fine. But yeah, we have to re-engage some of the quads. For the sake of my treatment, I would say let's re-engage some of the quads. They're pulling effectively, make sure that kneecap is a little more stable so it doesn't shoot laterally again. I think that's pretty much it, though, for the sake of patellar dislocations. And I think that's mostly through the knee. If I missed something, please let me know. All right, hit me up on social media, send me an email. Let me know your thoughts. I hope that you learned something today that covers most of the knee and the knee injuries. I would love to help. If you are concerned about whether or not your injury is a big problem, then let me assess it. All right, let's do a proper assessment. If you get any of the vibes today that you went into a doctor and they're telling you have a meniscus tear and you need surgery, but they didn't touch your knee, I would love to assess your knee for you, because you need to do the proper assessment to know exactly what's wrong with it. You can go straight to an MRI. It's just more cost effective, in my opinion, if you say, hey, let's find out what the heck is going on to help guide those decisions, because why spend money if you don't have to? All right. I hope you learned something today. Thank you for tuning in, and we will see you next time for the hip. See you next time.